Dear colleagues, we have the satellite symposium of MEDTRONIC and Professor Petrov. The stage is yours.
Dear colleagues, it's like continuation of the previous topic, and we are going still to speak about the balloons in above and below the knee. So, like we have just commented the three options: simple balloon, or stent, or to add the drug coating balloon. These are the most popular strategies nowadays, and but the guidelines still favor the ballooning. What about? Fortunately, the simple balloon is not the ideal way to treat above and below the knee lesions. The main problem of ballooning, we know that, for example, SFA, in most of the cases, they are long calcific lesions, and we need really or one very long balloon inflation or several inflations with shorter balloons. But nevertheless, because of the nature of the pathology, the local dissection is probably the main problem of plain balloon intervention, like shown here in with different devices, Lutonic, Stellarex, and Impact Admiral. We can reach the rate of dissection occurring in more than 60%, and especially it's concerning to have flow limiting dissection, not A, B, and C type of dissections, but D, E, and F, in which in most of the cases all over the world the bailout procedure is to implant stent. And the stent is carrying the risk of restenosis, more than obvious, because of the stimulation of the proliferation. Like shown here, in more than 80% of the cases, the bailout is stenting. So you see the rate of dissection occurring. You see that unfortunately in 60% of the cases the dissection is severe. So the so-called non-flow limited dissection is only in 40%. So as you can see, in almost half of the patients with elective ballooning, we have to implant stent in order to improve the immediate result, because there is a direct relationship between the immediate result and late result. Regarding new technology, so the normal balloon inflation, the regular balloon inflation, like shown here, there are several non-beneficial mechanisms. This is the unfolding expansion, and the shear stress is uneven all along the balloon itself. So there is a radial and longitudinal expansion, and the longitudinal expansion is causing the so-called shoulder effect. So on the two tips of the balloon, there is a significant risk of tissue and vessel wall damage and dissection. And because of that, during the time, there were strategies of non-compliant balloon, scoring balloons to redistribute the tension of the balloon over the vessel wall more evenly in order to avoid local shear stress and local dissection. One of the next strategy is shown here. This is the so-called chocolate balloon. Many things about the chocolate balloon as a scoring balloon. In fact, it's not. Why not? Because the nitinol wire is not outside. It's not on the surface of the balloon, but it's inside. It's in fact containing the pressure. So it's becoming, because it's the structure of the balloon is multi-segmental, this is in fact containing the pressure over the vessel wall, not only radially but also longitudinally. And this is the way in which we have much better distribution of the tension of the balloon over the vessel wall. Okay, several words about the indication and how to inflate. So we have to inflate after calculating one-to-one ratio in comparison to the reference diameter, not more. So oversizing is not a good idea. And one-to-one is a very good choice because the even inflation of the balloon is absolutely enough to open the artery, the stenotic artery properly. Second, it has to be inflated very slowly, and it has to be inflated for a long time, so at least for 1 minute in order to overcome the natural resistance and the trend for recoil of the vessel. So these are the principles of inflating the chocolate balloon. That is the new technology. So several examples of tissue damage from the simple regular balloon. You see the dissection, the circular dissection on several pictures, and especially when we have oversizing. So oversizing is not a good idea, but even with oversizing, you see that the oversizing is the biggest on the third column, where is the chocolate balloon inflation tissue shown, and you see how smaller compared to the other two is the local dissection of the vessel wall. Okay, I told you already that at least 1 minute, better 1 minute and a half to inflate the chocolate balloon in order to have the perfect result. This is the chocolate bar study, both above the knee, superficial femoral, and below the knee cohort. They are evenly 50 to 50% distributed, and from here it's very nice to see that multiple risk factors patients and with more than 20% total occlusions and with significant calcification. What we have spoken, the calcification is the enemy of even and predictable inflation. So this is quite a complex cohort of patients that was studied. What about the flow-limiting dissection, freedom from flow-limited dissection, and hence the freedom from bailout stenting? Excellent results. Adjudicated results, it's 100% flow-limited dissection freedom, and freedom from bailout stenting, it's 98 and 99 respectively. So it's for us it seems unbelievable. So because all we know that at least in our daily practice, at least in 30 to 50% of the ballooned SFAs, we have to implant a stent. And of course, the clinical result is also, this is the most important, this is the hard endpoint. And the hard endpoint is speaking have freedom from major implant amputation more than 95%. Taking a look by historical point of view on the data behind, we see that in these trials, compared to other trials, the probability of flow-limited dissections and bail-out stent placed is much lower, dramatically lower, compared to the data from Marc Bouzier from Belgium, compared to the absolute PTA and resilient PTA arm. You see that really the difference into the numbers is unbelievable. So, as a summary, I would say that optimal balloon angioplasty can lead to very good acute result, and we need slow and prolonged inflation to have a good result. Finally, we can predilate, but not always. It's not always so necessary. And the results from the chocolate bar registry show freedom from flow-limited dissection very close to 100%. I will show you several cases from our practice. All of them were with very symptomatic patients with multiple risk factors and multiple vascular pathology. The first one is a patient with distal lesions, posterior tibial artery with several critical stenosis. And this patient here was a diabetic one. Diabetic patient with distal stenosis on the above and below the ankle, with several critical stenosis. In this situation, this in fact was our first case to use the chocolate balloon. This is the Trailblazer supportive catheter in order to cross the lesions. And after crossing the lesions, in order to avoid bailout stenting with coronary balloon in most of the cases in this situation, we inflated the chocolate balloon on different levels of the posterior tibial artery, prolonged inflation with very slow inflation in order to overcome the resistance of the lesion on all levels of the pathology. And we were happy to see a really perfect result with excellent flow and absolutely acceptable residual stenosis. The second patient is a male, 76-year-old, with multiple risk factors, with a low ankle brachial index on the right leg, with quite a long SFA occlusion starting from the ostium. And for this very calcific lesion, you see also the critical stenosis of the profunda. So it's a patient that we crossed, in fact, firstly the wire into the profunda, and we tried several times to cross also the proximal cap. Finally, we succeeded with the Super J, the Terumo wire, that we like very much, the Super J wire, because it's there is quite a big probability to stay into the lumen or to go back into the lumen even after performing a dissection. So it's really a very, very good wire. So after the crossing of the lesion, we interchanged with 014 wire, that is the chocolate balloon compatible. And we performed several long inflations of the chocolate balloon. This is the balloon coming. I'm showing by purpose this picture in order to see that even without predilation it's possible to cross even total occlusion lesions directly with the chocolate balloon. But of course, it's probably better to have some vessel preparation first, and after that to finish the inflation with the prolonged inflation of the chocolate balloon. This is the final result. And you see that it's unbelievable, in such a huge calcific lesion, practically no dissection. So it was even for us a surprise, because this was the first femoral case that we have done. And we had performed also a kissing balloon on the level of the profunda and the ostial SFA in order to keep open also the profunda as a future bailout. So this is the final result. You see really excellent result without the need of stenting in this situation. It's more than obvious. So this is the final case with a critical limb ischemia on the right side, 68-year-old gentleman with a total occlusion, not within the stent, but also starting from the ostium of the SFA. It was not very easy. I had to use, in fact, this is the third in-stent occlusion, and we had to use the Confianza Pro 014 wire in order to go back within the lumen of the stent, because the wire has the tendency to go aside, so to make a dissection and even to go around the stent. So this is the crossing within the lumen of the stent with the Confianza Pro. That is one of the most aggressive coronary wires, and this is crossing the distal popliteal occlusion. So it was staged occlusions on the level of the SFA and on the level of the popliteal artery. it was was the first inflation with 6 millimeter by 220 millimeters long simple balloon. You see not very even and absolutely insufficient expansion at 16 atmospheres. So next step was the chocolate balloon, both on popliteal level. You see how to overcoming the critical stenosis, in fact, the occlusion of the popliteal artery, and also how even is the inflation on the level of the stent. And this is the final result after this repetitive restenosis and reocclusion of the SFA. Okay, and this is a case from yesterday. This is a case from yesterday with the critical stenosis of the short critical stenosis of the SFA. This is extremely suitable for chocolate balloon in order to predictably avoid stenting. This was after the 5 millimeter balloon. We checked by high definition assist device, and we saw very interesting that there is a still significant residual stenosis and some dissection and residual stenosis, you see. So we inflated on a second step a 6 millimeter, so 1 millimeter higher compared to the previous by 80 with a very prolonged low pressure inflation. The surprise was twofold. First, the dissections was less, so we had less dissected segment. This was the contrast injection that you saw within the lumen. And the second was that the residual stenosis is practically zero. So it was definitely proven by two methods, angio and TIVUS, that we had, and this is the final touch in order to improve the long result, the long-term result in this lady, and this is the final result I saw below the knee. As a conclusion, I would say that the chocolate balloon is a next-generation peripheral balloon reducing flow-limiting dissection, bailout stenting need, and improving the late patency rate in challenging above and below the knee peripheral vascular pathology. And thank you very much for your attention.
Yeah, the instant restenosis is very nasty. So if you go in with a balloon, you cannot expand the stent. You have some residual dog boning in the stent. That's the nasty one. And we don't have a good solution for that. Sometimes it is good going with a chocolate balloon there, but sometimes it's not enough. And then it is off-label. Sometimes you can do it with an atherectomy from the MEDTRONIC. I think this is off-label. It's also contraindicated. You shouldn't do that. The firm says that, but the only indication is you have to remove that material that is in the stent. So that's the only way doing that. But with a chocolate balloon and instant restenosis, it was a good result.
Yeah, absolutely right. We have different other technologies like shockwave balloon, like atherectomy and other devices in order to overcome the resistance of the material there. And but I think that the chocolate balloon is a very elegant option, and especially in the long in-stent thrombosis. After the first ballooning, I was absolutely disappointed, and we were thinking about even to place stent in stent. But after making the chocolate balloon inflation, it was some kind of wow effect. It was really the effect of the scoring balloon without damaging the tissue. It was really very interesting.
This is a plain balloon. We have also chocolate touch with drug coated on it.
Yeah.
Are you using it also?
Yes, exactly.
Okay.